Chapter 12, Principles of Emergency and Disaster Preparedness. The priority concept in this chapter is safety, teamwork, and collaboration. Coronavirus disease 2019, the pandemic also known as COVID-19, is the epitome of a disaster defined as an event in which illness or injuries exceed resource capabilities of a healthcare facility or community because of destruction and devastation. This kind of event can be either internal to the healthcare facility or external from situations that create casualties in the community. Both internal and external disasters can occur simultaneously, such as the COVID-19 began externally in the community setting and then overwhelmed internal resources at healthcare facilities across the world. An event occurring inside a healthcare facility or campus that could endanger the safety of patients or staff is considered an internal disaster. The event may create a need for evacuation or relocation. It often requires extra personnel and the activation of the facility's emergency preparedness and response plan, also called an emergency management plan. Examples of internal disasters include fire, explosion, loss of critical utilities, including electricity, water, computer systems, and communication capabilities, and violence, an active shooter situation. Each healthcare organization develops policies and procedures preventing these events through organized facility and security management plans. The most important outcome for any internal disaster is to maintain patient safety and visitor safety. An event outside the healthcare facility or campus, somewhere in the community, that requires the activation of the facility's emergency management plan is considered an external disaster. The number of facility staff and resources may be inadequate for the incoming emergency department patients. External disasters can be described as natural or anthropogenic or man-made. Examples of a natural disaster include a hurricane, earthquake, volcano eruption, or tornado. Anthropogenic disasters may be accidental, such as a truck rollover with hazardous materials or a malfunction of a nuclear reactor with radiation exposure, or purposeful, such as an act of terrorism with explosive devices. Examples of external disasters include the mass shooting in the Pulse nightclub in Orlando, Florida in 2016, and at the Las Vegas Harvest Music Festival in 2017. Hurricane Harvey, with incapacitated parts of Texas in 2017, Hurricane Ida, which affected Louisiana and Mississippi in 2021, and the 2021 California wildfires. Internal and external disasters can result in many casualties, including death. Multiple casualty and mass casualty disaster events are not the same. The main difference is based on the scope and scale of the incident, considering the number of victims or casualties involved and the severity of the effects. Both types of disasters require specific response plans to activate necessary resources. In general, a multiple casualty event can be managed by the hospital using local resources. A mass casualty event overwhelms local medical capabilities and may require the collaboration of numerous agencies and healthcare facilities to handle the crisis. State, regional, and/or national resources may be needed to support the areas affected by the event. Trauma centers have a special role in all emergency preparedness activities because they provide a critical level of expertise and specialized resources for complex injury management. To maintain ongoing disaster preparedness, hospital personnel participate in emergency training and drills regularly. In the United States, the Joint Commission mandates that hospitals have an emergency preparedness plan that is tested through drills or actual participation in a real event at least twice a year. One of the drills or events must involve community-wide resources and an influx of actual or simulated patients to assess the ability of collaborative efforts and command structures. Accredited healthcare organizations are required to take an all-hazard approach to disaster planning. Using this approach, preparedness activities must address all credible threats to the safety of the community that could result in a disaster situation. Disaster drills are ideally planned based on a risk assessment or a vulnerability analysis that identifies the events most likely to occur in a particular community. For example, a flood is more likely in the Gulf of Mexico, and an avalanche is more likely in ski areas of the Rocky Mountains. Because the threat of gun violence is now a risk to all communities, active shooter drills are commonplace in hospital care settings. It is essential that staff actively and seriously participate in the drills to increase their ability to act rapidly and maintain their ongoing competency. The importance of training has been emphasized in the wake of many disaster responses and has been credited for saving lives. Furthermore, literature shows that nurse leaders bring caring and resiliency to disaster response, so it is critical to stay prepared. After the Pulse nightclub shooting in 2016, Orlando Regional Medical Center, or ORMC, treated 44 victims, of whom 35 survived. Although there is grief for those lost, effective disaster planning and team preparedness accomplished well before this tragedy helped to save the lives of on the night of this event. Nursing homes and other long-term care facilities are also mandated to have annual drills to prepare for mass casualty events. For these agencies, as well as home care agencies and group homes, part of the response plan must include a method for evacuation of residents from the facility in a timely and safe manner in the event of a disaster. An evacuation plan is part of fire prevention and preparedness plans for healthcare facilities. The Life Safety Code, published by the National Fire Protection Association, provides guidelines for building construction, design, maintenance, and evacuation. The Centers for Medicare and Medicaid Services require every healthcare facility to practice at least one fire drill or actual fire response once a year. Patient evacuation is not required if the event is a drill. All facility personnel are mandated to have training in fire prevention and responsiveness each year. The events of September 11th in 2001 substantially and permanently changed hospital and community disaster plan efforts. With the shocking terrorist attacks of the Twin Towers of the World Trade Center and the Pentagon, the loss of life in the field in Pennsylvania, and the actual and perceived threat of domestic terrorism, including the anthrax exposure that followed, hospital emergency preparedness concepts became integrated into the daily operations of emergency departments by necessity. Weapons of mass destruction became a focus of public health risk. The term NBC was coined to describe nuclear, biological, and chemical threats. In response, emergency medical services agencies and hospitals improved safety by upgrading their decontamination facilities, equipment, and all levels of personal protective equipment to better protect staff. ED physicians, providers, and nursing staff now routinely undergo hazardous material training and learn how to recognize patterns of illness in patients who present for sickness that potentially indicate biological terrorism agents such as anthrax or smallpox. Protocols for the pharmacologic treatment of infectious disease agents and stockpiles of antibiotics and nerve agent antidotes are generally more readily available than in the past. The most significant outcome of improving emergency preparedness after September 11, 2001, was that the ability to competently handle the most typical multi-casualty or mass casualty event, such as a bus crash, tornado, chemical plant incident, or building collapse, was greatly improved in many communities. However, disaster situations, even today, can still exceed the scope of usual day-to-day crisis operations, pointing to the necessity of well-defined personal, facility, regional, and national emergency preparedness plans, as well as ongoing drills. From another historical perspective, Hurricane Katrina made landfall in 2005 in Louisiana and other Gulf states as a Category 4 storm that caused more than 1,000 deaths and devastating environmental and property damage. Volunteers from all over the United States and local, regional, and federal agencies took part in the large-scale disaster evacuation, rescue, and relief effort, which severely challenged available resources and established disaster plans. However, offices that provided and maintained license requirements were damaged or inoperable immediately following Katrina, which greatly affected the speed of allowing nurses into the state by providing needed care. Critical systems failed and were eventually reestablished through teamwork and collaboration among multiple agencies to ensure that the basic human needs were met. Hurricane Katrina overwhelmed the existing emergency care system and caused the mobilization of the National Mutual Aid Response on a level that had not been experienced in previous U.S. history. A pandemic, an infection or disease that occurs throughout the population of a country or world, leads to vast numbers of people who seek medical care, even though worried well. Although not yet ill, the worried well want evaluation, preventative treatment, or reassurance from a healthcare provider. A well-known global biological threat was the Ebola virus disease crisis that devastated West Africa from 2014 to 2016. This outbreak, although better managed, still continues. The COVID-19 pandemic remains a significant challenge, requiring a prolonged disease response. According to the Johns Hopkins Coronavirus Research Center, at the time of publication in 2023, there have been more than 676 million cases of COVID-19 worldwide, with more than 103 million in the United States, causing more than 1 million deaths. The world death toll was 6,881,955 when Johns Hopkins closed the data on March 10th of 2023 after 3 years of around-the-clock tracking. Because of the mass casualty nature of infectious disease pandemics, emergency preparedness planners collaborated during the outbreak of COVID-19 to incorporate strategies for large-scale testing to determine whether patients tested positive for COVID-19 and for the handling of the very high influx of ill patients into the healthcare setting. The first wave of the pandemic lasted until May of 2020 and caused hospitals to encounter significant challenges with bed capacity and all types of resources, including PPE, cleaning supplies, ventilators, and medications. Staff engaged in teamwork and collaboration to create new models of care and increase bed capacity throughout the hospitals to meet the sudden high demand of critically ill patients. Quarantine of selected nurse units or the entire hospital became necessary in some demographics. Hospitals developed and maintained surge plans that were well-defined, repetitive, updated frequently, and required clear communication. Elective surgical and procedure-related admissions were canceled, which freed up beds and staffing resources to be redeployed to areas of the hospital, providing care to patients with the COVID-19 virus. Nurses, other professionals, and assistive personnel were among the staff roles. The nurses underwent a rapid orientation to their new assignment, which were often very different from the nurses' usual specialty or practice area. These surge strategies enabled bed capacity to be increased to promote hospital flow to decompress crowded ERs. Many emergency departments also erected disaster tents and hospital parking lots to expand ED treatment capacity. Some institutions repurposed parking garages and erected temporary buildings for additional beds. The National Guard deployed in multiple states to support the effort with healthcare personnel and manpower. The most recent global pandemic, the novel coronavirus disease of 2019, also known as COVID-19, caused by a severe acute respiratory syndrome, the coronavirus 2, or SARS-CoV-2, arose at the end of 2019 as the causative agent of a cluster of pneumonia cases. It quickly spread worldwide due to its high infectivity and rate of contagion. COVID-19 was declared a pandemic on March 11th of 2020 by the WHO. In the response, larger than had been since the 1918 H1N1 influenza epidemic, global industries closed or relocated employees to work from home. Retail establishments, restaurants, flights, and cruises were closed and canceled for months. Schools serving K-12 students, colleges, and universities shifted to remote online learning to discourage large assemblies of people in classrooms. Many general populations were sequestered to home under different levels of quarantine in an effort to provide containment of the virus. Patients who were exposed were placed into immediate isolation. Personal protective equipment, ventilators, and oxygen were in scarce supply in many parts of the world. This brings up the concept of a mass casualty triage. Common to all mass casualty events, the goal of emergency preparedness is to effectively meet the extraordinary need for resources such as hospital beds, staff, drugs, PPE, supplies, and medical devices. The U.S. government stockpiles critical equipment and supplies in case there is a need for a pandemic infectious disease outbreak and organizes large-scale vaccination programs. Each state has its own specific emergency preparedness plan. In the case of COVID-19, the United States has learned that these methods of preparedness need modification and enhancement to better meet the needs that arose as part of the pandemic. The pertinent communication and rollout surrounding COVID-19 vaccines and boosters have required significant large-scale emergency planning efforts and resources to effectively secure locations and qualified personnel to vaccinate all eligible individuals in the nation and world, as well as to track vaccination rates and research the outcomes. Triage functions may be performed by EMS providers in the field, such as emergency medical technicians and paramedics, nurse, provider, and physician field teams, which are called from the hospital to the disaster scene to assist the EMS providers, nurse providers and physician hospital teams to assess and reassess incoming patients. Triage concepts and mass casualty incidents differ from the civilian triage methods discussed in Chapter 10 that are practiced during usual emergency operations. Although disaster triage practices can vary widely based on local EMS protocols, some concepts are fairly universal. Most mass casualty response teams in the field, at the disaster site, and in the hospital setting use a disaster triage tag system that categorizes triage priority by color and number. Emergent or Class 1 patients are identified with a red tag. Patients who can wait a short time for care, Class 2, are marked with a yellow tag. Non-urgent or walking wounded are Class 3. Patients are given a green tag. Patients who are expected and allowed to die or are dead are issued a black tag, or a Class 4. Some triage models have a gray tag that is labeled expectant and a black tag that is labeled dead. The idea of putting a black tag on somebody is quite scary for most providers, but I will tell you typical examples of black tag patients are those from a massive head trauma, extensive full body thickness burns, high cervical spinal cord injuries necessitating medical ventilation. The rationale for this very difficult decision is that limited resources must be dedicated to saving most lives rather than expanding valuable resources to save one life as a possible expense to many others. In this system of triage, red tag patients have immediate life-threatening conditions such as an airway obstruction or shock and therefore require immediate attention. Yellow tag patients have major injuries such as an open fracture with a distal pulse and large wounds that need treatment within 30 minutes to 2 hours. Green tag patients have minor injuries that can be managed after a delay, generally more than 2 hours. Example of a green tag injury would include a closed fracture, a sprain, a strain, abrasion, and/or contusion. Green tag patients who are able to ambulate are often referred to the walking wounded because they are actually evacuate themselves from the mass casualty scene and go to the hospital in a private vehicle. Green tag patients usually make up the greatest number in most large-scale multi-casualty situations. Therefore, they can overwhelm the system and provisions are not made to handle them as part of the disaster plan. A related concern is that green tag patients who self-transport may unknowingly carry contaminants from a nuclear, biologic, or chemical incident to the hospital environment, with potentially disastrous consequences. ED staff must anticipate these issues and collaborate to devise emergency response plans accordingly, including appropriate decontamination measures. When the number of casualties exceeds the usual resource capabilities, a disaster situation exists. What may be considered a routine day in the ED of a large urban trauma center could be defined as a disaster for a small rural community hospital if the same number of patients arrive. Therefore, each facility decides when criteria to declare a disaster have been met. Flexibility is needed because resources may change by time of day and by day of week. For example, hospitals typically have the fewest staff available after midnight on the weekend. An incident that occurs is this time frame may require activation of the emergency preparedness plan to bring extra resources into the hospital. The same incident during a weekday business hours might be handled with on-site personnel alone without the need for activation of the plan. Notification that a mass casualty or multiple casualty situation exists usually occurs by radio, cellular, or electronic communication between the ED and EMS providers at the scene. A state or regional emergency management agency may also notify the ED of the event. Each hospital has its own policy that specifies who has the authority to activate and how to activate the disaster or emergency preparedness plan. Group texting or paging systems, telephone trees, and instant computer-based automated alert messages are the most common means of notifying essential personnel of a mass casualty incident or disaster. A catastrophic event, such as a major earthquake or tornado, or a terrorist incident involving weapons of mass destruction, also requires the teamwork and collaboration of volunteers from all members of the healthcare team in the region. The media may be contacted to facilitate communication by broadcasting messages to the healthcare community at large via television, radio, or social media. Social media continues to be used more frequently in times of disaster for citizen reporting, community organizing, and problem solving and volunteer recruitment. For such incidences, the National Guard, the American Red Cross, the Public Health Department, various military units, a medical reserve corps, or a disaster medical assistance team can be activated by state and federal government authorities. As a medical reserve corps is made up of a group of volunteers of medical and public health care professionals, including physicians, providers, and nurses. They offer their services to healthcare facilities or to the community in a supportive or supplemental capacity during times of need, such as a disaster or pandemic disease outbreak. These groups may help staff hospitals or community health settings that face personal shortages and establish first aid stations or special needs shelters. As a means to alleviate ED and hospital overcrowding, the Medical Reserve Corps may also set up an acute care center in the community for patients who need acute care but not intensive care for days to weeks. A disaster medical assistance team is a medical relief team made up of civilian medical, paraprofessional, and supportive personnel that is deployed to the disaster area with enough medical equipment and supplies to sustain operations for 72 hours. DMATs are part of the National Disaster Medical System in the United States. They provide relief ranging from primary health care and triage to evacuation and staffing to assist healthcare facilities that have become overwhelmed with casualties. Because licensed healthcare providers such as nurses act as federal employees when they are deployed, their professional licenses are recognized and valid in all states. Additional examples of services provided by the NDMS include the disaster and mortuary operation teams to manage mass fatalities, the National Veterinary Response Teams for emergency animal care, and the International Medical Surgical Response Team to establish fully functional field surgical facilities wherever they are needed in the world. The facility-level organizational model for disaster management in the Hospital Incident Command System, which is part of the National Incident Management System, implemented by the Department of Homeland Security and FEMA to standardize disaster operations. In this system, roles are formally structured under the hospital or long-term care facility incident commander with clear lines of authority and accountability for specific resources. Officers are named to oversee essential emergency preparedness functions such as public information, safety and security, and medical command. Chiefs are appointed to manage logistics, planning, finance, and operations as appropriate to the type and scale of the event. In turn, chiefs delegate specific duties to other department officers and unit leaders. The idea is to achieve a manageable span of control over the personnel or resources allocated to achieve efficiency. FEMA offers free courses on the NIMS model and HICS structure through its website at www.training.fema.gov. Because mass casualty events typically involve large numbers of people and can create a chaotic work environment, many EMS agencies and healthcare facilities use brightly colored vests with large lettering to help identify key leader positions. Specific job action sheets are distributed to all personnel with leadership roles in HICS that predefine reporting relationships and list prioritized tasks and responsibilities. The HICS personnel are also established an emergency operations center or command center in a designated location with accessible communication technology. They then use their collective expertise to manage the overall incident. All internal requests for additional personnel and resources and communication with field teams and external agencies should be coordinated through the EOC to maintain unity of command. The roles and responsibilities of healthcare personnel in a mass casualty event or disaster are defined within the institution's emergency response or preparedness plan. Each plan is individualized as the particular facility's operations, yet virtually all plans identify key certain functions. One of the primary roles to be established on the onset of an incident is that the hospital incident commander, who assumes overall leadership for implementing the institution's plan. This person is usually either a physician in the ED or a hospital administrator who has the authority to activate resources. This role can also be fulfilled by a nursing supervisor functioning as the on-site hospital administrator after usual business hours until the hospital leadership personnel arrive. The hospital incidents commander's role is to take a global view of the entire situation and facilitate patient movement through the system, while bringing in personal and supply resources to meet patient needs. For example, a hospital incident commander might dictate that all patients due to be discharged for an inpatient unit be moved to a lounge area immediately to free up hospital beds for mass casualty victims. The incident commander could also direct departments such as physical therapy or a surgical clinic to cancel their usual operations to convert the space into a minor treatment area. The incident commander assists in the organization of hospital-wide services to rapidly expand hospital capacity, recruit paid or volunteered staff, and ensure the availability of medical supplies. Another typical role defined in hospital or other healthcare emergency preparedness plans is that the medical command physician. The role focuses on determining the number, acuity, and medical resources needed of victims arriving from the incident scene to the hospital and organizing the emergency healthcare team response to the injured or ill patients. Responsibilities include identifying the need for and calling in specially trained providers such as surgeons, trauma, neuro, orthopedic, plastics, and/or burn, anesthesiologists, radiologists, pulmonologists, infectious disease physicians, industrial hygienists, radiation safety personnel. In small hospitals with limited specialty resources, the medical command physician might also help determine which patients should be transported out of the facility to a higher level of care or to a specialty hospital. An example, a burn center or a trauma center. Closely affiliated with the medical command physician and the triage officer. This person is generally an emergency physician in a large hospital who is assisted by ED triage nurses. When physician resources are limited, an experienced ED nurse may assume this role. The triage officer rapidly evaluates each person who presents to the hospital, even those who come in with triage tags in place. Patient acuity is reevaluated for appropriate disposition to the area within the ED or the hospital best suited to meet the patient's needs. Many other roles and responsibilities can be defined within the institutional emergency response plan and may include the supply officer, the communication officer, the infection control officer, and the community relations officer or public information officer, to name a few. The community relations officer or public information officer is an especially important role to delineate in advance. Mass casualty incidences tend to attract a large amount of media attention. This staff member can draw media away from the clinical areas so that essential hospital operations are not hindered, and can also serve as a liaison between hospital administration and the media to release only appropriate and accurate information. Nurses function in a key role before, during, and after a disaster. The core components of the nursing process apply in the overall assessment of the emergency situation, the identification of needs, capabilities, and priorities, assessment and determination of needs, planning, implementing, and evaluating the disaster response. Before an event, nurses contribute to developing internal and external emergency response plans, including defining specific nurse roles. Nurses take into account the security needs, communication methods, training, alternative treatment areas, staffing for high demand or surge situations, and requirements for resources, equipment, and supplies. They then test the plans by actively participating in disaster drills and evaluating the outcomes. If outcomes are not as desired, nurses help to modify the plan of action. During an actual disaster, the ED charge nurse, trauma program manager, and other ED and hospital nursing leadership personnel act in collaboration with the medical command physician and triage officer to organize nursing and ancillary services to meet patient needs. Telephone trees or automated group notification systems may be activated to call in ED nurses who are not working or are not scheduled to work. ED areas are identified and prepared to stage, triage, resuscitate, and treat the disaster victims. Efforts are made to quickly discharge or admit other ED patients as appropriate to make room for the new arrivals. ED nurses apply principles of triage to prioritize care delivery as disaster victims enter the system and direct patients to the designated areas best suited to meet their needs. Nursing roles in disaster extend to all areas within a healthcare facility. The level of involvement is determined determined by the scope and scale of the disaster. In any mass casualty event, nurses from critical care and medical surgical care units may be asked, in collaboration with the healthcare provider, to recommend patients for transfer or discharge to free up inpatient beds from disaster victims. Patients who are most medically stable may be discharged early, including those who were admitted for observation and are not bedridden, are having diagnostic evaluations and are not bedridden, are soon scheduled to be discharged, or could be cared for at home with support from family or home health care services, have no critical change in condition in the past 3 days, could be cared for in another healthcare facility such as a rehabilitation center or a long-term care facility. This picture is a go bag. This is an example of a collection of personal readiness supplies. Basic supplies are for personal preparedness would be a 3-day supply, and it would include a backpack, clean, durable, weather-appropriate clothing, sturdy footwear, portable water. They say at least 1 gallon per person per day for at least 3 days, food that's non-perishable and does not require cooking, a headlamp or a flashlight that's battery powered with extra batteries and or chemical light sticks, pocket knife or a multi-tool, personal identification with emergency contacts and phone numbers, allergies and medical information, list of credit card numbers and bank accounts kept in a watertight container, towel and or washcloth, towelettes, soap and hand sanitizer, paper, pen, and pencils, regional maps, a cell phone and charger, sunglasses, protective and or corrective eyewear, an emergency blanket and or sleeping bag and pillow, work gloves, personal first aid kit with over-the-counter and prescription medications, rain gear, a roll of duct tape and plastic sheeting, a radio, battery-powered or hand crank generator, toiletries such as toothbrush and toothpaste, comb, brush, razor, shaving cream, mirror, menstrual supplies, deodorant, shampoo, soap, lip balm, sunscreen, insect repellent, and toilet paper, plastic garbage bags and ties, resealable plastic bags, matches in a waterproof container, a whistle, and household liquid bleach for disinfection. When the last major casualties have been treated and no more are expected to arrive in numbers that could overwhelm the healthcare system, the Incident Command considers standing down or deactivating the emergency response plan. Although the casualties may have left the ED, other areas in the hospital may still be under stress and need the support of the supplemental resources provided by emergency plan activation. Before terminating the response, it is essential to ensure that the needs of the other hospital departments have been met and that all are in agreement to resume normal operations. A vital consideration in event resolution is staff and supply availability to meet ongoing operational needs. If nursing staff and other personnel were called in from home during their off hours, or if they've worked well beyond their scheduled shifts to meet patient and department needs, provisions for adequate rest periods should be made. Exhaustion poses a risk for patient safety and to nurses when they must drive home. Sleeping quarters at the hospital might be necessary in this case, especially if the disaster event contributed to treacherous travel conditions. Severe shortages of supplies pose a threat to usual operations. Taking inventory and restocking the ED for high priority assignments following a disaster or mass casualty event is very important. Teamwork and collaboration between the ED and the Central Supply Department are essential to resolving stock availability problems. Instrument trays must be washed, packaged, and re-sterilized. Contracts with key external vendors outlining emergency resupply expectations and arrangements should be made as part of the hospital's overall emergency preparedness plan so that the service can be undertaken quickly after an event. 2 general types of debriefing, or formal systemic reviews and analysis, occur after a mass casualty incident or disaster. The first type entails bringing in crisis support teams to provide sessions for small groups of staff to promote effective coping strategies. The second type of debriefing involves an administrative review of staff and system performance during the event to determine whether opportunities for improvement in the emergency management plan exist. Crisis workers with special education and training in physiologic first aid and behavioral health address pre-crisis through post-crisis interventions for small to large groups, including communities. After working through the turmoil and the emotional impact of the incident and the aftermath, the staff may find it difficult to get back to normal. Without intervention during and after the emergency, they are at risk for developing acute stress disorder or post-traumatic stress disorder. Acute Stress disorder, although similar to PTSD, focuses on dissociative symptoms such as numbing, reduced awareness, depersonalization, derealization, amnesia, experienced within the first month after a traumatic event. PTSD can lead to multiple characteristic psychological and physical effects, including flashbacks, avoidance, less interest in previously enjoyed events, detachment, rapid heartbeat, and insomnia. People with PTSD can have great difficulty relating in their usual way to family and friends. Ultimately, professional burnout can stem from the inability to cope with the stress effectively. A resource in the Internal Crisis Incident Stress Foundation. Their mission is to provide leadership, education, training, consultation, and support services in comprehensive crisis intervention and disaster behavioral health services to the emergency response professions, other organizations, and communities worldwide. Research indicates that education and training in disaster management before an incident occurs is associated with improved confidence and better ability to handle situations that arise. The second type of debriefing in an administration evaluation, also known as a hot wash, directed at analyzing the hospital or agency response to an event while it is still in the forefront of their minds of everyone who participated in it. The goal of this debriefing is to discern what went right and what could be improved during activation and implementation of the emergency preparedness plan so that needed changes can be made. Typically, representatives from all groups who are involved in the incident come together soon after the plan activation has been discontinued. They each are given an opportunity to hear and express positive and negative comments related to their experiences with the event. In the days after the plan activation, written critique forms are also solicited to gain additional information after participants have had time to consider their overall impression of the response and the impact it had on their respective departments or clinical areas. Although drills are important, implementing the emergency preparedness plan during an actual mass casualty event is the most effective means of reality testing the plan's utility. Feedback provided by participants can be used to modify or revise the plan and create new processes in preparation for future events. During a community disaster, nurses and other emergency personnel may be needed for triage, first aid, or emergency care and shelter assistance. The initial action of first responders in a disaster is to remove people from danger, both the injured and uninjured. Firefighters and other disaster-trained emergency personnel typically manage this job. Unless they have had a specific pre-hospital search and rescue training, nurses are not usually involved in this process. In all cases, developing and maintaining accurate situational awareness are critical for appropriate priority settings and safety in the rapidly changing environment. After removal from danger, victims are triaged by healthcare professionals, as described earlier in this chapter. After triage, nurses often provide on-site first aid and emergency care. They may also be involved in teaching and supervising volunteers. The American Red Cross sets up shelters for people who have lost their homes or have been evacuated from their homes. Nurses may need to teach those living temporarily in shelters about procedures that may be necessary for safety when they return home. For example, clean drinking water may be unavailable for several days or longer, so community residents may need to boil their water before drinking. If electricity and gas are unavailable, an outdoor grill or camper stove may be used for this purpose. An alternative procedure, commercial water purification filters, sterilizing ultraviolet pens, or 10 to 20 drops of chlorine bleach without perfumes added to a gallon of water will make the water safe to drink. One of the most important roles of the nurse during and after a community disaster and health assessment, an action in which nurses recognize cues, including psychosocial health. Experiencing a disaster can produce both immediate and long-lasting psychological and psychosocial effects in people personally affected by the event. Depending on the nature and magnitude of the event, survivors experience the tragic loss of loved ones, pets, property, and valued possessions. They and their loved ones may have experienced injuries or illnesses brought about by the catastrophe. Lifestyles, roles, and routines are drastically altered, preventing people from achieving any sense of normalcy in the hours, days, and perhaps even weeks and months that follow the disaster. Coping abilities in survivors are severely stressed, leading to many individual responses, which can range from functional and adaptive behaviors to maladaptive coping. Survivors have to confront feelings of vulnerability resulting from the devastating events known that can occur again. This may be particularly relevant in issues for people who live in areas prone to acts of terrorism or natural disasters. The decision, be it voluntary or involuntary, to abandon a family home or geographic region and then relocate to a safe area, either temporarily or permanently, can result in a sense of loss, grief, or disorientation. Some people may feel guilty about living through an event that caused others to die. The range of intense emotions can manifest as physical illness as well as psychological and social dysfunction. When helping people in crisis after a mass casualty event, be calm and reassuring. Establish rapport through active listening and honest communication. Survivors benefit from talking about their experiences and putting them in chronological order, which provides clarity and helps them begin to problem solve. Offer resources whenever possible to help talk through and about the experience, and survivors can gain a sense of personal control. Help survivors adapt to their new surroundings and routines through simple, concrete explanations. Convey caring behaviors and provide a sense of safety and security to the best extent possible. If available, request that crisis counselors respond and assist in providing compassionate support to victims and their families. Survivors also are at risk for development of acute stress disorder or PTSD, as noted earlier. Nurses caring for survivors with symptoms of ASD or PTSD should perform further assessment by using a tool such as the Impact of Events Scale. The IESR, a 22-item self-administered questionnaire, is the most widely used assessment created to assess current distress related to a traumatic event. It includes several subscales such as avoidance. Before giving the tool, determine the patient's reading scale because it is written at a 10th grade reading level. The tool should not be used for patients with short-term memory loss. For this reason, many older survivors often are inadequately assessed for post-disaster PTSD. Depending on the patient's presentation and nursing assessment findings, remember that behavioral health evaluation and referral to counseling may be appropriate.